So today I'm going to speak about symptom management and supportive care and talk about how important it is to be in a team. I'm being directed by the director. I'm not used to. I'm a movie star. How important that it really is a team approach. If we as clinicians, as physicians, as nurses, as nurse practitioners, if we don't know what symptoms you are struggling with, we certainly can't help you. Thank you. First of all, I want to thank Dave and Gabrielle and Martine and the rest of Myeloma Canada for inviting me today. It's my first time at a Myeloma conference, a Myeloma Canada conference, and I'm terribly impressed. And the last day and a half, I think, has been quite phenomenal, and I think we should give the Myeloma Canada people a round of applause. So I have no financial disclosures. I just mentioned to someone I haven't done my taxes in a while, so I certainly have no financial disclosures. The only thing I really need to disclose is that I need a 12-step program for reality TV. And as Dave mentioned, I have been a nurse for 39 years. I developed an interest for pain and symptom management and palliative supportive care when I was about 8 years into my career. I was caring for boys with HIV/AIDS, all of whom were facing a terminal illness, and something sort of clicked with me. So from there, I went forward. I know that a senator in the States has recently mentioned that nurses play cards a lot, and they're not really working. And yeah, in 39 years, I've got to say, all I know is Go Fish and maybe Crazy Eights. So certainly no card playing here. So we've heard a lot over the last day and a half about all the great things that are coming forward with myeloma and all the new treatments. Our physician colleagues, Reese Chen, Hay McCurdy, Neary, they goes on, talking about all the new things in the pipeline, which is fantastic. This is great news. The challenging news for all of you and clinicians like myself that try to manage symptoms is that the longer myeloma patients are living, the more treatment protocols you go through, the more symptoms you're going to have to manage. So even though it's absolutely fantastic, even in the 5.5 years I've been at Princess Margaret, and I have a very unique role at PM, I'm finding it more and more challenging to manage and help manage all of these symptoms for patients. The biggest challenge, I think, in myeloma is we're not really sure if it's the myeloma that's causing the distress or the treatment or a bit of both. And if you look at underneath the heading myeloma, we see hypercalcemia, your calcium is high, your kidneys might not be very happy, and your creatinine starts creeping up. Most patients I see are transfusion dependent. They have anemia, thrombocytopenia, neutropenia being supported by Grastafil or Neupogen, pain. Lots of myeloma patients have pain. I'm sure many of you know. We look at bony pain, if there's bony disease. A lot of neuropathy, although as many people have mentioned back in the day, a long time ago we gave Velcade intravenously, then we were giving it subcutaneously twice a week, and now with weekly dosing we don't see as much neuropathy. Patients with myeloma get infections. A lot of people have talked this weekend about how myeloma is truly a cancer of the immune system because it affects the plasma cell. Fatigue, I see a lot of patients with chronic fatigue related to their disease, and it's because of many reasons. Depression, anxiety, and for some reason I have infection twice on my slide because it's really important. When you go over to the treatment side, infection's right at the top. So you're already at risk for infection being a myeloma patient, being under treatment, and then we start adding all of these cancer-treating agents, and we put you at higher risk. There's risks for DVT or blood clots, more renal dysfunction, GI disturbances such as diarrhea and constipation. Again, pain is there. It never seems to go away for some patients. Again, low counts. We see a lot of people that have been on many of the agents needing transfusion support, depression, anxiety, and fatigue. So when you look at the slide, it really shows how difficult it is for me as a clinician to figure out where this is coming from. But in the big picture, it really doesn't matter. We're going to manage all of these things the same way. The important thing again, though, is if you're too Canadian and you don't complain, you're not going to be feeling as well as you can, because we have many, many tricks up our sleeves. Tricks up our sleeves that aren't necessarily validated by science, but we know from our own practices can work quite well. So poorly managed side effects really do have consequences. And the physiological issues such as unmanaged pain, other side effects can result in insomnia, anorexia, sexual dysfunctioning or sexual functioning. And from that, then we get into psychological issues. So we didn't get on top of the side effects, and now people have depression, anxiety, and low self-esteem, which can often go back to the sexual functioning. And then that ends up impacting all of your social connections because you're so tired, you're feeling so lousy, and it starts really affecting all of your relationships, both at home, and at work, and other social contexts. So again, the importance of letting us know what you're going through, I can't stress enough. After all of that, that's when patients really start struggling to adhere to treatment. And I've had many, many patients the last 5 years. Now, granted, I don't generally see patients up front upon diagnosis. I see them much later after years of treatment. But many, many patients have told me they've had enough. And when I ask them what it isn't about going to the hospital necessarily. It isn't about even having to be on transfusion support or hydration support. It's all of these other symptoms such as anxiety, insomnia, depression, chronic pain, which is exhausting. So without treatment, and again, we've heard this weekend all of the exciting things that are coming. If we can't keep you on the treatment that we have right now, you're not going to benefit from treatment that's coming next year or the year after. So we really, really have to work hard to keep people well and, make sure that we can keep you on treatment. So we have to work together. I've never climbed a mountain. I will point that out. Right there, I can see me falling and breaking a hip. So the first thing we look at is pain. And as I just mentioned, chronic pain, acute pain is awful, but acute pain is something that, you sort of figure I've got this really bad pain right now, but with the right medication, I will be able to move forward. But when the pain becomes chronic and every day you wake up and you still have that throbbing pain in your back or the neuropathy or even gut pain, it just becomes so fatiguing and so distressing. And there are so many things that we can do, again, if we know about what you're going through. So there's many, many medications that we can use for pain. I want to point out, opioids are not a bad choice in many, many cases. And I know that it's been all over the news the last couple of years about an opioid crisis. That crisis is not within your group, all right? This is not relevant to cancer patients across North America. If we need to use opioids to manage your pain so that you continue on treatment, that you continue having good relationships with your loved ones and your lover and your friends and all of those things, please don't be afraid of opioids. Please don't be afraid of opioids. We also use bisphosphonates very often for bone pain, and my dear colleague Donna Reese yesterday was talking about, how often, how long we should leave people on bisphosphonates. It's always something to discuss with your team because every patient is different. Analgesia, we had someone talk yesterday about cannabis. I have used a lot of cannabis in my practice. I also grew up in Montreal in the 70s. I won't say anything else. I have purple hair. So there's many things we can do sort of from a chemical perspective. And then there's other things. I mean, it's sort of difficult to understand sometimes how increasing activity can help with pain. The majority of myeloma patients, not all, but the great majority of us are in this room are over a certain age. And so we have other chronic pains on top of you. I don't mean to mean that I have myeloma, but you have other pains related to the normal aging process. And if that sort of pain isn't managed, then your myeloma or your cancer pain can be exacerbated. So we know with things like arthritis, good activity, good weight management certainly makes people feel better. Someone spoke briefly yesterday on kyphoplasty and vertebroplasty. I've had great success with patients of mine that I follow that have had kyphoplasty specifically, that have gone from huge doses of opioids to almost none sometimes. And I had one guy who was like 6'7" to begin with, and he'd lost 7 or 8 inches in height because he had so many compression fractures, and he even gained 2 inches back, so he was feeling pretty sexy, I must say. Radiation therapy. Radiation therapy in oncology medicine is very different with the myeloma patient than it is with, say, breast cancer patients or colorectal cancer patients, prostate, where the radiation is part of the treatment. We don't use radiation in myeloma as a treatment modality as such, but we use what we refer to as palliative radiation to treat lytic lesions that are causing pain. And the reason that it's called palliative radiation, just so that you don't get worried, is because the intent is not cure, the intent is to treat symptoms. So, and if you just a little bit, if you have new pain or the person that you love has a sudden new pain, it needs to be reported, and I talk about it later, as soon as you can to your team, because you might have an impending fracture. And if you end up having to go into hospital and have your hip replaced, you're going to have to go off treatment. So there's a bit of a discussion this morning about complementary and alternative medicines. I know that many people in this room are grasping for anything that will help them. And I will reiterate my physician colleagues this morning saying, be very, very, very careful. Because a lot of this stuff that we see patients are on, we don't know what it is, we don't know if it will interfere with therapies, and we don't know if it will in fact enhance or make your cancer worse. So I think, get your vitamins from a decent diet. As the doctor said, vitamin D, all my patients are on vitamin D. I also have many patients on magnesium for sleep and muscle cramps, and sometimes for constipation. I have had patients that have had good results with acupuncture. Acupuncture really is not invasive, and it's not systemic. So I've had a couple of patients that, for neuropathic pain, have done very well with acupuncture. Sorry, I'm dry. So, back pain. Back pain, we want to know about new back pain as soon as you can let us know about it. As you all know, myeloma can affect the spine in 2 ways. It can affect the bones in the spine, the vertebrae, which can become compressed, and the pieces of bone compress on the spinal cord. Or you can have a new myeloma soft tissue mass within the spinal cord area. This can result in a malignant cord compression, and we use the word malignant because it's related to cancer, and it is a medical emergency. If it is not treated immediately, some patients will be paralyzed from the place of the compression down for the remainder of their lives. So it's something to just keep in your mind. We can image and make sure that it isn't something that we need to worry about. So back pain is very, very, very important to report to your team. Any thoughts on pain? I'm supposed to ask at the end. Sorry, I usually just chat. So, as I mentioned, I had infection 3 times on my slide. Cancer patients across the world are worried about infection because their immune systems are compromised because of treatment and or their disease. All little kids know that hand washing, they're taught this in school, that hand washing is, the thing to do. And it is absolutely your best defense anywhere you go. Most infections are transferred from mouth to hand to surface. Droplet infections, such as pneumonia and coughs, we call them droplet infections because when we cough, they drop at 2 feet. So the idea of wearing a mask everywhere isn't necessarily always the best protection. I worry sometimes that my patients think, well, I've got my mask on, and the masks only last 20 minutes on average, so you have to change it a lot, that they feel much more protected. In actual fact, they're going to pick something up because I've wiped my nose, very classily, I might add, and then I've touched something. You come on, you lean there, you put it near your face, and then you've got my bug. The bug I've got is not going to hurt me. I'm a big, healthy girl, so far. Avoiding crowds, and the reason we talk about crowds is that 2-foot droplet infection. If you're on the subway in Toronto or the metro in Montreal or whatever you do out west, we are like face to face and back to back with people, and they're touching everything as well. Even places of worship, especially during holidays or really important times of worship for that particular congregation, it's really important that you try not to get in that crowded church or mosque or synagogue. Avoiding sick people, it's pretty obvious. If someone comes to your house and they're coughing or snotty, and I know we love our grandchildren sometimes, but let's face it, those kids are full of boogers. They need to go home. Because even though apparently there's no science behind it, but I swear to God, 2-year-old snot is way more infectious than 25-year-old snot. So love them, keep them at length, and because they will touch everything. Good personal hygiene. Now, I don't want to sort of imply that people don't shower and bathe and brush their teeth, but some people don't. And part of my role at the Princess Margaret is some of the patients that I see up front upon diagnosis as they're getting ready to go to transplant or they're beginning treatment, a lot of those patients are marginalized and they're homeless, they have addiction histories, they have mental health histories, and people with schizophrenia, they don't tend to bathe. And if you think about all the bugs that are on your clothes and you're wearing the same underwear and not brushing your teeth, it makes sense that having a good shower is not a bad idea. Next, we talked a little bit, I think Donna Reese was talking yesterday in one of her talks about prophylactic acyclovir. Most of the docs, I work with 6 physicians, 6 myeloma specialists at the Princess Margaret. I must say they all do something different. It's sort of hard to keep up. But the majority of them keep their patients on acyclovir for the rest of the patient's life. Again, as it was mentioned, it doesn't have a lot of side effects. It's really well tolerated, and shingles is awful. It is absolutely awful. Shingles can go anywhere. It can go in your eyes, your mouth, your genitals, your brain. It's a bad thing. So when I see patients and they want to reduce some of their medications because unfortunately they're getting more into their end of life, I always say let's stay on the acyclovir. A lot of physicians will prescribe antibiotics for bacterial prophylaxis. Now, my 6 docs, they all do it differently. Suzanne Rowland likes levofloxacin, someone likes Septra. Whatever your clinician, your physician suggests or prescribes to you, I would hazard a guess they know your disease best. They know your comorbidities best. So when you're sitting in the waiting room and you're talking to Bob, and Bob says, well, I've never been on levofloxacin, that's because you're different, Bob. You're really different, Bob. No. So, vaccinations. Unfortunately, around the world, we have had measles coming back. I don't really understand why some young parents think that vaccinations are evil. I, in fact, have a 32-year-old son that ended up with a frontal brain injury because of a vaccination, but I assure you, my grandchildren are vaccinated. It was just bad luck. And if I get the measles, I'll be okay. But if you guys get the measles, or babies get the measles, it's not okay. So you really, again, we're Canadians, we don't like to be rude. But if you have a cousin and you know she's an anti-vaxxer, don't let her kids come over. Just do not be around them, because it would be just awful if you guys picked up the measles. Really, really awful. So as far as vaccinations, we talked yesterday about no live vaccines. And the reason is, I'm not a doctor by any means, so I think very simplistically. A live vaccine is just, we inject an actual virus into your body. And if you don't have a good immune system because of your disease, you're not going to be able to fight that live vaccine and create new antibodies. So that's why we don't have live vaccines. Now, Chris Chen yesterday said they're talking about what we'll do about measles. I have a patient with Donna Reese who was going to Asia, very worried about measles. And what I did is I drew her titers to see if she has immunity left from when she was vaccinated as a child. If she doesn't, we might give her high doses of IVIG before she goes. So there are some things we can do to get around. Apparently they've been doing that in Ottawa. So no measles, no mumps, no chickenpox. The old zoster we don't give, but the new Shingrix, which I thought was really expensive. My physician colleague over there told me it's only about $160 over 2 injections. You can get that. You can also get polio, rabies, Hep A. We want you to get your annual flu shot. We know that the flu shot doesn't always work in every year, but it's better than nothing. And you should all have your pneumococcal vaccine. So that's the vaccine against pneumonias, and you need that every 10 years. All of us over 50 need to have that vaccine anyway. So, have a lot of people in this room had upper respiratory infections? Yeah. And it sort of comes on really fast. And, if I get a cold or a cough, I'll feel lousy for a day or two and it'll go away. But for patients on treatment or patients that have been on treatment, things can change very, very, very quickly. And you can have a normal viral upper respiratory infection to turn into pneumonia before you know it. So if you're coughing, and it's a lousy cough, it's like that horrible cough that you get, especially if you're bringing up sputum, we need to know. If you're actually having trouble catching your breath, we need to know. If you have a fever, and I know you all know about, you need to go or you need to call, whatever your rules are. If your temperature is above 38.3, you need to let us know. The other thing, and that should say below 35, I apologize. If you have a temperature of below 35 Celsius, and many people don't know this, below 35 Celsius can be a sign of sepsis, and you need to let someone know. So you take your temperature, it's 34.8, you wait 15 minutes, you take it again, and if it's still down there, you should probably go to emerge. Okay, so that's something that people, for some reason, aren't really told about, but it's important. So prompt management of an upper respiratory infection can certainly often prevent pneumonia, or at least get pneumonia under control quite quickly. And as mentioned, many patients will be on prophylactic antibiotics. And if you are on prophylactic antibiotics, I would take you off your prophylaxis, put you on something different and maybe a bit better, and then when you're done that 10 days or 14 days of antibiotics, then we'll put you back on your prophylaxis. I think we did talk about thrombosis yesterday. So just as sort of a recap, also a medical emergency, especially the PE. That is definitely a medical emergency. So anybody that has a central line, especially PICC lines, which we use a lot, at least we use a lot in where I work. If you've got a PICC line in and you look down and your arm is significantly a different shape or a little bit bigger than your other arm, we want to know about it. It can be warm, it can be painful, but it might only just be swollen. It doesn't necessarily have to be hot. It can often feel tight if it's not painful because, the skin is being stretched. Some patients will tell me, I've been feeling like my heart's been racing, and it's just the body's response to something not going on that isn't good. The skin can be red, and then if you have a really, really significant deep vein thrombosis or thrombus, you can actually start having blue extremities because it's cutting off the circulation to your digits, if you may. So we need to know about that. Sometimes if the clot is on the line, we won't need to pull it, but we will need to put you on anticoagulants. So that's the DVT side. The PE, and people that have had a history of DVTs, that for whatever reason they're no longer on anticoagulants, and they have good platelet counts, are certainly at a much higher risk for PEs. And a PE is most definitely a medical emergency. If you have any of these signs, you need to call 911 because this is something that is manageable, but you have to be in hospital. So if you're really having trouble breathing, you're having some chest pain, and often patients will tell me, it's the weirdest pain, it's sort of in the tip of my shoulder and it's sort of in my back. That is alarming. People get very anxious because you're not getting enough oxygenated blood to your brain because of this pulmonary emboli, so people start getting really anxious and sort of restless. And again, your heart rate will get really rapid. So much, much better to feel foolish and sit around in an emergency department for 48 hours, but it's much better to make sure that you don't have a PE. All right. So, and someone did speak about this yesterday. Risk factors, any cancer patient, it's not just myeloma, anybody, any cancer patient is at a higher risk for any sort of clot, active disease. The IMIDs have made things even harder, so most people on Revlimid or Pomalyst will be on aspirin. We talked about central lines. If there's a family history or personal history of previous clots, immobility, I remember when I was a kid, well, mind you, I was smaller, I suppose, but in an airplane, you could actually stretch your legs. And now if you go on one of these all-inclusives, God, the seat in front of you is like on your lap, so you can't really move. So it's, ask for an aisle seat so you can get up without feeling rude, that you have to crawl over people and move around. Smoking's just bad, we know that. And being chubby is not so great either. But, sometimes at this point in your life, having a little extra weight on you won't hurt you. So management strategies for clots, the myeloma treatment itself can sometimes help with clotting. We look at using the appropriate blood thinners or things like heparin and warfarin and the new DOACs that were spoken about yesterday. I must say, my team and myself, we generally do not make any of these decisions. We ask the thrombosis team to help us because it's certainly a subspecialty. The elastic stockings, the anti-embolism stockings, which are just horrible. They're better than they used to be, mind you. But they can help and they can bring down some of the swelling. They used to be so bad and so hard to put on that I actually went into premature labor with my first child trying to put a pair on a lady after surgery. So they are a bit better. Lifestyle changes, getting into some exercise, moving around a lot. Like even sitting here for a long time, it's good just to get up and move around. And again, travel precautions. Talk to your team. Should I, remain, I've stopped Revlimid, but I'm traveling to, now that I'm off treatment, I'm going to go and do Europe, and I'm traveling. Should I stay on my aspirin for a couple of weeks? Just chat with your people. So there's a couple of GI things that people struggle with. The first is diarrhea. A lot of people on Velcade struggle with diarrhea. And also is that we put you on laxatives because we have you on opioids, and then the laxatives sort of take over, and it gets to be a bit difficult to manage. Anybody had C? Oh, you don't want to tell me if you had C. diff. C. diff is awful. And I have a lot of patients asking me for antibiotics. You know, I've coughed 3 times, I think I need to be on antibiotics. And although we're more likely to give antibiotics in this patient population than your average Joe seeing a family doc, we don't want to just be willy-nilly, because C. difficile is one of these superbugs that came to be in the 80s because of overprescription of antibiotics. And C. diff is a terrible thing to go through. Nobody likes to poop their pants in public. It's just not fun. So we want to just avoid that. And you can actually die from C. diff. Magnesium supplements, I mentioned a lot of my patients. I have them on magnesium at bedtime to help with muscle cramping, to help with sleep, to help with low magnesium because their kidneys are upset. But that can also give you some loose stools. Some antidepressants, although not so much the newer antidepressants. And then again, your supplements. So I'm not a big supplement person. People are things like milk thistle, aloe, cayenne, saw palmetto, ginseng. They all give you the trot, so why bother? Not only is your urine more expensive, but now your poop's more expensive too. So managing diarrhea, we need to make sure it sort of doesn't, you know, it sort of makes sense when you think about it. I mean, if you're losing fluid, you need to replace your fluid. But some people say, well, I don't want to drink anything because I'm just going to end up back in the bathroom. But we have to keep fluid on board. Looking at diet, some people, you know, some of you really healthy people that only eat pure good food, some of that is really high in fiber. And sometimes there's nothing wrong with a piece of Wonder Bread once in a while, because that's not going to give you diarrhea. And then looking at antidiarrheal medications such as Imodium or Lomotil, but we need to make sure, and this is terribly important, that you don't have C. diff. Now, any old nurse worth a grain of salt can tell C. diff just by looking and smelling. C. difficile is a bacterial infection of the gut, which gives you terrible diarrhea, terrible, terrible diarrhea. So once we rule out C. difficile by sending a specimen to the lab, if it turns out your diarrhea is related, especially to your treatment, then we can get you on some antidiarrheal medication. So on the other end, if we're not making you poop too much, we're making you too constipated. So I know that every time you go to clinic, I'm sure, how much water are you drinking? Are you drinking 2 liters? You got to drink water, you got to drink water. You have to drink water, folks. It's really important. Diet can certainly contribute to constipation, maybe too much Wonder Bread and not some of that good bread. I said misuse of laxatives. I don't mean that you're misusing them like on purpose, but you know, sometimes it takes a while to figure out a good balance for stool softeners and laxatives. And opioids. And as I mentioned, opioids are not a bad thing. But, and it doesn't matter, you know, some people have told me, well, I don't want to be on hydromorphone, I want to be on oxycodone because hydromorphone makes you constipated. All opioids will make you constipated, every single one. So if you're on opioids, when I start someone on opioids, I immediately start them on some sort of bowel routine right from the get-go so they don't get bunged up. Because getting a bowel obstruction with stool is very, very uncomfortable. So management, getting into a real routine with your bowels is there's something to be said about that. Just sort of training your body that, you know, every morning when you wake up or whatever works for you, that your body gets used to using the toilet sort of around the same time of day. And again, using your laxatives and stool softeners as prescribed, but also, as I said in the beginning, if you're too polite and you don't tell us you're struggling with this stuff, we can't help you. So again, you know, constipation, as I mentioned, can be a medical emergency. You really too can get a true bowel obstruction just from being constipated. So renal myeloma loves the kidneys. Loves the kidneys. And, you know, as mentioned yesterday a couple times, myeloma can go anywhere in the body. It really loves the kidneys, and that's why looking at kidney function is one of the CRAB criteria. So risk factors for decreased or impaired renal function is the disease itself, is if you have hypercalcemia related to the myeloma, if you already have a history of kidney problems such as kidney stones, now that you have myeloma, you might be at higher risk for renal insufficiency. And then other medical issues. It's been mentioned a number of times that myeloma tends to be a disease of older people, although we do certainly see people that are younger. But the older we get, the more comorbidities we get. So things like diabetes and lupus already affect the kidneys. So again, we want to really keep an eye on things. I can't say enough about drinking water, and to really, really concentrate. What's that? One of the tricks I use, I say, well, I forget all day, or I can't do it, and I get that sometimes drinking that much water can make you feel awful, and we do understand that. But sometimes reminders, putting out 4 water bottles in the morning, you have to finish them. Go to the dollar store and get a plastic pitcher that you used to make Kool-Aid in for kids, mark off 2 liters, put a Sharpie mark there, fill it up when you make your coffee in the morning, and you've got to drink the whole thing. So at 3 o'clock, if it's still full, you're going to be peeing all night. So certain medications are excreted through the body in different ways. And we know that NSAIDs, so things like Advil, which is ibuprofen, Motrin, Aleve, these are all considered NSAIDs, and they are excreted through the kidneys. So we don't want you taking NSAIDs. Morphine is also excreted through the kidneys. And in my practice, I don't use morphine in myeloma patients. I use hydromorphone because it's much, much easier on the kidneys. Peripheral neuropathy, a lot of people have mentioned this. We talked about sub-Q bortezomib or Velcade has been better. Then there's been some anecdotal evidence for B vitamins, fish oil, and lipoic acid, whatever that is. Again, we don't really have any evidence for this. We'd rather you just take vitamin D. A lot of people will say that with their neuropathy, they have cramping in their legs and sometimes in their hands. We certainly have seen good results with tonic water. A little bit of gin wouldn't hurt at the end of the day. It'll help you sleep. Pedialyte is much easier to drink than like Gatorade, which can be pretty harsh. But Pedialyte, I went to see Billy Idol a couple of weeks ago. I'm just an old rock person. And, Billy Idol in his day was just absolute mess. And he was actually drinking Pedialyte instead of straight vodka during his performance, so we all get old. Another thing that physiotherapists taught me is that if you're having cramping in your legs, to get one of those stick roller things you can pick up and really roll your muscles, because the cramping can be a buildup of lactic acid, so that can often be helpful. Safety, if you have peripheral neuropathy, especially in your feet, you want to really know that you have to be cognizant of safety, that you don't want to fall because you can't feel the floor beneath your feet very well. So throw rugs are a bad thing. You want to wear shoes that fit. Water temperature, if you can't feel how hot the water is when you get into the bath, you can burn yourself. If symptoms worsen, sometimes we do have to adjust chemo, either the scheduling or the actual drug. And then I've had significant luck with Lyrica. I find, though, if we don't sort of treat people early on when their neuropathy is starting, I have trouble getting on top of it. So again, it's all about letting the clinician know. Some antidepressants have been shown to work with neuropathy, although I think that the efficacy isn't quite what we would hope for. So again, report symptoms to promote safety and quality of life. Bone health, we talked a little bit about this, I think, yesterday. Many myeloma patients have bony disease. We want to protect you. We want you to be on your vitamin D. You want to check with your clinician before taking calcium. If you have some hypercalcemia, we certainly don't want you taking calcium. And bisphosphonates, so that can help. Those can help strengthen the bones. Weight-bearing activities. I mean, if you are able to do some walking, even short distances every day, it can help with your bone health and your hips. You want to report bony pain immediately. As I mentioned before, we want to know right away, because if you have new hip pain, and I send you right down, get an x-ray, and I can see a lytic lesion, then we can get you into radiation, hopefully the next couple of days so you don't get a broken hip. This is most of us usually. Quality of life when you're anxious, when you're fatigued, when you're depressed, it just wrecks everything. And we get really bitchy. I mean, if you're not happy and things aren't going well, you feel pretty bitchy, and then that affects everything else. So, there's many sources that can contribute to these things, and I believe that Dr. Google is one of the biggest culprits. I am so impressed this weekend on how informed and smart myeloma patients are. I'm blown away on how smart y'all are. I think most of you know more than I do. But Dr. Google will just make your anxiety worse because a lot of stuff that's out there is not validated. I mean, you want to turn to your hematologist and speak to them directly. So, and anxiety, fatigue, and depression, transfusion support, if you need it, if it works, if it makes you feel better, it can be a game changer. Different medications. I use a lot of Ritalin in my practice for people with chronic fatigue. If anybody wants to ask me later, I'll let you know. Resting when you need to rest, but we know in the cancer world, resting, like long periods of rest, is not a good thing. We want you to really keep going and pushing through. People with heart failure, we say you got to lay down every afternoon for 3 hours. But in short periods of rest can sort of reinvigorate you. Psychosocial support if it helps. And also, I think it's important to work to still be you and not be your disease. I think that makes a huge difference in the way people continue through. And I think in this room, even though you're all very well informed, oh, for God's sakes, he keeps holding up this time thing. 10 minutes. So you want to be yourself. I mean, you still want to do what you can do when you can do it. It'll make you happier. So there was a question this morning about, why are we all still on Dex? As I said, we know Dex sucks. It makes a lot of people feel terrible. It makes a lot of patients' spouses feel terrible. Sometimes creative scheduling. Some patients like to set their alarm at 3 in the morning and take their Dex then. Sometimes that works better. I've got a couple of patients that take it at night. I don't really understand that. One guy said, well, that way I'm awake all night and I'm not bugging my family. So it's... with steroids, you want to protect your stomach. Most people are on a PPI when they're on dexamethasone. It's really important that you don't stop it. There are some over-the-counter medications you can take to protect your gut as well. Weight management, I mean, steroids make us chubby, but it's not really the end of the world. If you have blood sugar concerns, you want to stay on top of that, because if your blood sugar is always high and you've got neuropathy from your Velcade, then your blood sugar is high, then you're going to get more neuropathy because your blood sugar is high, so you want to just keep an eye on that. We also know that people on steroid treatment are more prone to infections, so I've already nagged you about infections and reporting fevers. Even if you've heard the word rigering, where you've got the shakes, we want to know about that to make sure you don't have an infection, especially if you have a central line in. So just some common myeloma drugs, and you know them all, and there's more coming down the way. You can just see how many side effects these drugs have. But without these drugs, people won't do as well, and we can manage side effects. So again, it's really important you let us know what's going on. In the end, the goal of myeloma treatment is to keep people well for as long as we can keep them well. So wonderful physicians like Dr. Neri can come up with all these new treatments through all their clinical trials. And that's where we have to aim. That's where we have to aim. My whole practice is about quality of life, because I figure, we can keep you alive for an extra 8 years, but if everything is awful and you can't eat and you can't sleep and your relationship's broken down and you can't walk because you've got neuropathy, I don't know that there's really much point. So we have to work really hard looking after all of these other things. So again, you're all going to live longer than you would have even 3 years ago, 5 years ago, certainly 20 years ago, and this is a great thing. But we need to be informed. You need to talk to your team. You need to let them know what you're going through, no matter how dumb or minuscule you might think it is. If it's important to you, I assure you it's important to me. And those of us that are a wee bit older, that have been around a long time, we've seen it all. And there's nothing you can't tell us. Absolutely nothing you can't tell us. So a healthy lifestyle is great, you know, walk and do all that stuff, but have some fun as well. There's nothing wrong with having a cookie. There's nothing wrong with staying out late once in a while if you feel up to it. I mean, being yourself is, you know, I sort of believe, I mean, my physicians wouldn't necessarily agree with me, but I think that, you know, there's something about good food and laughter and love and music and art and all of these things that contribute to our lives that may be just as important as some of the treatments we give you. Keep your form in-teamed, changing your medications. Many of you have many prescribers. If you go to see Dr. whoever and then Dr. whoever and one changes something and then they change it again, please let us know so we can keep on top of things. Medication reconciliation is so very important because without good med reconciliation, your symptoms will get out of control. Okay, so polypharmacy, that's what that's called. Share your concerns. Symptoms and side effects can only be addressed if you let us know. Bring questions with you, write them down. I know it's hard to remember everything. Have someone with you in clinic so that you, in case you forget something. And thank you very much.
We have time for a few questions. Sophia.
That was excellent.
Thank you.
There are some side effects of particular new agent, new
Yes.
drugs, that they call it so-called uncommon, but really they figure out that it's coming. One example is about the impact on the eyes.
Yes.
With selenexor, even Valcade called style.
Yes.
But now they are learning that it does impact that. Dex also impact the pressure on the eyes, and so there are these studies. Eyes are very important, and I found that many new medical treatment, they impact eyes. So it's good to address and figure out how to deal for patient to have a quality life.
Thank you. Thank you. I'll remember that next time. Appreciate that.
Thanks. Excellent talk, Suzanne. Thank you for making it so real. Recently, my mom had diarrhea, and her doctor had her go on Floraster, which is like, you know, like there's all these 80 billion probiotics, 80 billion cell probiotics. Do you recommend that for us when we have infections, or is that too much?
Can I give this answer over to my myeloma pharmacist colleague, because I don't think I know the answer. She's just sitting over there with the gray sweater and the, yeah, thank you. Thank you. This is Alexa, also from Princess Margaret, one of our pharmacists.
Thank you. Generally, for cancer patients in general, but same with myeloma, we don't recommend probiotics because it is a bacteria. So generally, for the general population, we use it to repopulate your gut with good bacteria that might have been wiped out with, you know, antibiotics or whatever. But where this population is immunocompromised, we're worried about infections, as you guys know. So we generally don't want to introduce any bacteria at all, good or bad. So generally we say please avoid. But I guess you could look at it individually based on your own blood work, your immune system at the time, whatever. But generally I would say no.
Thank you. Now we all know.
I've got a couple of quick questions from the floor. Should we take Shingrix vaccine if we're still on acyclovir?
Yes.
Okay.
Yep, the answer
Thank
is
you.
just yes. Yep.
All right.
We have
Oh.
Okay.
Yes.
Two very quick questions. As part of my protocol for a transplant last year, I went through all of the vaccinations that were required.
Yes.
No one ever mentioned, I have a question. As a child, I obviously had the measles vaccination. Did any of my stem cells transplants wipe that out? And another very quick question is, if you're on Zometa, which is what I am in my case, would it be counterintuitive to still be on a calcium supplement, or should people stop the calcium supplement if you're on a bisphosphonate?
Well, I think if you're on, first of all, if you're on bisphosphonate, I mean, it's something you should, as I said, everybody's individual disease, although we're all under the myeloma umbrella, there's many, many different types and different things going on. So some patients that have really, really, really bad bony disease can often be on calcium and Zometa or pamidronate or another bisphosphonate. So that's really an individual thing. I forgot your other question. Sorry. Yes, sorry, the measles. So yes, so you can ask either your family doctor or wherever you're going for treatment to draw your measles, your titer, to see how much immunity you have to measles. You won't be able to get the measles vaccine, but at least you'll know that, if you have a visitor and they say, oh, she's just been diagnosed with measles, or you're on a plane and there's this rashy looking kid, then you'll sort of know where you are with your immunity.
Yeah, I spoke to you briefly yesterday about my wife in particular, about drinking enough fluids.
Yes.
And you brought it up in the talk that you have to drink, and people like her, she doesn't drink enough of the fluids, and I can't get her to. But now she's also complaining she's up all night peeing.
Yeah.
And how is she peeing? Because she doesn't drink enough fluids. Is she just peeing up the medicine? Is that what's happening?
Well, I mean, it's sort of when you're drinking during the day. And actually what happens sort of physiologically, the reason we all need to pee when we lie down is because we lie down and all the urine goes into our bladder. So sometimes I'll tell people to sort of lay on the couch for a little while before you actually go to bed, which might get you peeing before you go to bed. It is a problem. I mean, it's a safety issue because people are up going to the bathroom during the night. All I can say is try and start drinking earlier during the day. And don't be too hard on her. I mean, there are some patients that just cannot drink enough. And sometimes those patients need hydration support at home to keep the kidneys happy. For some people, it's very, very hard.
Excuse me, I'd like to know about the tetanus shot. You never mentioned that.
Didn't I? I thought, yes, tetanus, you can have tetanus, sorry. Yes, absolutely.
Okay.
Absolutely have tetanus.
One more thing.
Yes.
My doctor prescribed vitamin D, 10,000 units once a week.
Oh, interesting.
No, you don't know about that.
No, I don't.
Oh, okay.
Oh, pharmacist is standing up.
Yes?
Alexa might have something to say.
The vitamin D that's dosed like that, the high dose once a week, it's vitamin D2. It's just slightly different than what we traditionally see as the vitamin D3. As maybe a 1,000 per day, for example. The vitamin D is just a bit of a different form. Some people find a once a week dose easier. It really doesn't matter, probably physician preference. But depending on your kidneys and your liver, sometimes we like different forms. The D3 is more common, but the D2 is another one out there, yeah.
This is why I'm in touch with pharmacists all day long, because they're smarter than I am in a lot of stuff.
One more thing about
sorry.
peripheral neuropathy.
Yes.
You said you have lots of tricks up your sleeve for different things.
Mm-hmm.
Have you any for that?
Well, unfortunately, not so much for that. Peripheral neuropathy, again, my experience is if we get on top of it early on, and if it wasn't, the only thing that I've had patients come back and tell me is that acupuncture was very helpful. And myeloma patients can have acupuncture as long as their immune system's not sort of, as long as they have neutrophils.
Okay, we have time for one more question. Suzanne, are you able to stay around for
Sure.
a while later today?
Sure, of course.
Okay.
Okay.
One last question.
I was quite alarmed when I'm right here at the front.
Oh, sorry,
I was
thanks.
quite alarmed when you said that the masks, the facial masks, are only good for 20 minutes. Have you got any strategies you can recommend for us if we're doing commercial air travel on how to avoid? Obviously, we're
those masks. I'm thinking, did I talk about going to the salon or the spa? Those masks. No, really. So what happens with those, regular masks that we have in Haw that you can pick up a handful is once they're wet. So you're breathing and you have moisture in your, when you exhale, they're no longer effective. So just take a bunch and change them every 20 minutes. Yeah, half an hour that will do. And if you start coughing, change it after you cough.
Okay, Suzanne, thank you so much for offering to stay around for a while later today. And please feel free to approach Suzanne, and thank you so much
You're very welcome.
for
Thank
an
you.
excellent presentation.